Hey guys, Hidayat here. Dalam video kali ini kita akan go with another episode of The Good Doctor, episode 2. Kita akan buat medical review like the previous video. Shall we start? So basically dalam video kali ini, what I'm doing is I will just comment roughly throughout the episode. It's not about the specific babak, tapi it's basically the whole episode.
Nausea. And a lot of pain apparently. Did you give her morphine?
Yeah, 10 milligrams. Hasn't touched her pain.
You have time to get a CT?
Budding the aorta and the left kidney. Renal angiomyolipoma?
You see an extensive blood supply?
No.
Maybe some kind of neurogenic tumor or maybe a lymphoma.
She has a sarcoma, a malignant tumor.
A new case that the patient presented dengan abdominal pain, okay, and then they did a CT scan. So basically when you are not really sure what is going on with the patient, when you palpate the abdomen and then the abdomen doesn't to feel like there's a mass or anything, or you are not really sure what is really going on, basically you akan order CT scan, okay, contrast enhanced CT scan untuk tengok the organs inside. This time there's a tumor dalam CT scan. It's just near to the left kidney and it's abutting. Abutting maksud dia macam tolak tekan aorta kita punya huge, very big vessel lah untuk supply the whole abdomen, okay, and also lower limb. It's gonna be a risky operation. It depends on the tumor. Kalau the tumor is well defined, then it's easily to remove. But if the tumor is malignant looking, maksud dia akan possible infiltrate the surrounding organ intraoperatively, then it's gonna be very, very difficult. So sarcoma meaning that there's a connective tissue. It's a tumor of the connective tissue lah, basically. Okay.
You have an ear infection?
Yes, that's why he's here.
My hearing's been a little muffled and I've had some rain.
They gave him amoxicillin and we're sending him home, which is why you're here, to send him home.
I'd like an MRI of the head and internal auditory meatus.
Patient ada ear infection, basically maybe otitis media, something like that, ataupun external infection, and started with antibiotics, and suddenly Dr. Sean requests for MRI. Basically it's not necessary at all. With suddenly you want to request MRI. MRI is very, very expensive. Let's say kalau you go to the private, it is not cheap. If a simple infection doesn't look like very much complicated, you are not thinking of malignancy, ataupun you are not thinking of possible brain tumor that may causing the ear involvement. There's no CSF fluid that coming out from the ear. Kenapa nak buat MRI? You are not supposed to do it. It's not necessary at all. So end up, actually, Dr. Sean is wrong for this patient and it's not necessary at all. Kalau you tengok, Dr. Sean ni involved with a lot of patients and sometimes he involves with ENT patient. Surgical residents, ENT is another subspecialty. Usually every hospital has ENT lah, ear, nose and throat punya medical officer ataupun doctor. I don't think he's required to do ENT punya job lah. Maybe in other hospital dekat US, UK, they have no ENT punya specialist or specialty.
She had her deviated septum repaired. Before we can release her, we have to be sure she isn't suffering from postoperative ileus.
So another thing is just young patient doing just a simple, doing a deviated septum repair under GA. Suddenly kenapa Dr. Sean ni nak fikir pasal post-op ileus? Usually post-op ileus ni involved with a big surgery such as intra-abdominal surgery, hip arthroplasty, and involved with old patient, okay? That is usually the case. Young patient only involve the nose area, deviated septum punya operation. Usually most of the time, 99% of the time, they won't have paralytic ileus, meaning that the bowel movement is not moved yet post-operative.
Yeah, your heart sounds good. So we make a long incision down the middle of your abdomen, expose the tumor.
Am I going to die?
This female doctor, I lupa nama dia, saying that this is a laparotomy and we are going to do a midline incision. But actually it ends up differently and it is not a midline laparotomy.
You're not gonna die. You will be at the wedding, looking beautiful. Okay.
This surgical doctor promised to the patient that the patient is not gonna die and it will going smoothly. You are not supposed to promise good thing with the patient. This is the ethics. Major surgery usually akan end up with a lot of complication. Even though it doesn't end up with the intra-abdominal complication, but post-operatively, you might have to difficult to extubate, maksudnya remove the tube pernafasan, ataupun you punya lung is not expanding well post-operative. If you are not mobilizing, you will have a blood clot in your leg and then it will travel and block your main vessel of the lung. There is a lot of complication intraoperatively and post-operatively. So you are not supposed to make a promise that you know that there is a lot of uncertainties, especially if it's a intra-abdominal tumor.
Yes.
Does that hurt?
Yes.
Does that hurt?
How much are we paying for this? She has a tummy ache.
The parents?
Yeah. A little girl has a tummy ache because mommy and daddy won't stop fighting. This isn't a medical issue. Send them home.
Could be intestinal malrotation, which could quickly become fatal.
And every patient in this hospital could have malaria. But that doesn't mean we're going to go around testing for every condition we think they could have. For example...
So another case presented dengan abdominal pain and then Dr. Menendez thinking that nothing is going wrong with the kids. Okay, so for me, you need to have a proper serial assessment for the patient and then doing the proper physical examination. Sometimes the presentation is very vague. You must thinking of something that is more sinister. At this age, most of the kids usually akan presented dengan appendicitis. Okay, the presentation pretty much is very typical, usually over the right iliac fossa. But if it is non-specific abdominal pain, and then sometimes you need to just monitor, observe the patient, maybe 24 hours or 48 hours to make sure that the patient is really okay. Another sinister problem usually intussusception. Intussusception adalah situation apabila you punya bowel, okay, usus you and then termasuk ke dalam usus yang lagi satu. So dia akan berlapis. Jadi macam tu. The kids will have abdominal distension, perut kembung, muntah-muntah, and then bila diorang berak, usually mungkin looks like a red color jelly. Okay, so usually this will be a sinister situation and urgent intervention need to be done. At this age group, we are rarely thinking of intestinal malrotation. Intestinal malrotation most of the time happen very, very early because it's congenital defect and usually it occurs after birth.
Why are you smiling?
Because you're right.
So you thought he was making a mistake and didn't say anything? Just stood by watching, taking notes while he wasted everybody's time? Is that your job?
In my experience, doctors don't listen to nurses, and they only talk to us to lecture us when they figure we screwed something up.
So, Dr. Melendez ni marah staff nurse ni because dia tak tegur Dr. Sean doing everything on his own.
I'm Dr. Claire Brown. I'm first assist today, and I'll be leading the timeout. Patient's name?
Stephanie Willis.
Scheduled surgery?
Excision of an indeterminate retroperitoneal tumor.
We don't anticipate any complications with the surgery.
Thank you, Dr. Brown. 10 blade.
10 blade.
You will see that the patient actually lying on the a right lateral position, okay, and then the incision is at the below the rib region. We call it a subcostal incision, and it is not midline laparotomy like she mentioned initially when she consulted the patient for the operation.
Once we get through the muscle layer, proceed carefully.
Blood pressure 120/70, heart rate 60. She's holding steady.
I've opened the fascia.
So this female doctor, dia open up, and then there's a muscle layer, and then there's a fascia layer. It's called a gerota fascia that's surrounding the perinephric fat, and then you will see the kidney.
Whoa. We need a better exposure of this tumor. Now let's get the deep valve for in here.
Deep valve forward track.
Let's get this thing open. I gotta see where it's safe to cut. I can't see anywhere where the tumor hasn't encased her arteries. Claire, tell me you got something.
I've got nothing. This tumor is way bigger than it looked on the scans. I can't even see her aorta.
That's a problem.
The tumor act very aggressively intraoperatively, and they noted the tumor is encasing tu macam membaluti of the blood vessel. To me, I rasa it's more of a renal artery and also renal vein that supply the left kidney. The surgeon felt difficult to remove the tumor, and they need to think what is the possible way to remove the tumor for the patient to have a better prognosis.
The tumor is entirely encased the large abdominal arteries.
That's very bad. If it's in the artery walls, it's going to be impossible to cut out without killing her. You should get a biopsy to determine where the margins are.
Thank you.
You need to make a decision whether you want to proceed with the operation or you abandon the operation and take the biopsy. Hopefully, if it's a tumor that can be responded with chemotherapy ataupun radiotherapy, you will offer that to the patient. And the best part dekat dalam cerita ni, dia punya pathology lab is freaking efficient. You can go bring the specimen downstairs, they will read it. Maybe dalam 15 to 30 minutes, they will come out with the results. That is very efficient, and unfortunately, it will never happen in Malaysia, especially in government hospital. I'm not really sure about the private hospital, but I think it is pretty much the same too.
It's a leiomyosarcoma.
Well, that sucks.
Yes, it's sad.
The surgery's impossible.
Well, might as well wake her up. Let her know she has 3 months to live. Offer palliative care.
Surgery isn't impossible. Just very, very, very difficult.
Yes, in the sense that we'll be operating blind.
Yes, because the left kidney is in the way.
The healthy left kidney.
Both kidneys are healthy, Jared. She only needs one. Without the left one, it's theoretically possible to access the tumor and remove it.
You're suggesting we cut out a perfectly healthy organ just to get a better view?
Yes.
But she might die anyway.
Yes, quite probably.
The biopsy result that has been taken just now turned out to be leiomyosarcoma. It's malignancy of a connective tissue disease, and usually leiomyosarcoma ni is not respond to any kind of chemo ataupun radiotherapy. So usually the disease will progress by itself. Dr. Sean Murphy suggested to do left nephrectomy. Maksud dia, you remove the whole left kidney to have a better view of the tumor. It is logical because you only need one kidney for you to live. Okay, you can even donate your left kidney ataupun your right kidney, and you still can live like a normal human being.
That is it. I think you got it all.
You think?
No, you definitely did. I just can't quite believe it.
It's your idea.
And finally, the surgeon able to remove the tumor and the operation was successful. It's not a terrible idea to remove a perfectly healthy left kidney, but I'm not really sure what the urologist will say. You might need to tell the patient beforehand that there's a risk terpaksa end up with left kidney ataupun patient might die on table, because this is high risk surgery. So that's pretty much my commentary on this episode for the Good Doctor episode 2. I hope you guys really like it. If you really want more videos of this kind of videos, I hope you can comment down below and then tell me which episode or which series that you want me to review for you guys. Okay, see you in the next video. Bye.